Good morning and welcome to Southern Maine Healthcare's Medically Speaking. I'm your host, Robert Erickson, and for the next 30 minutes, you'll hear about medical issues and topics of the day directly from leading medical professionals at Southern Maine Healthcare. Welcome to this week's episode of Medically Speaking. Our guest today is Dr. Christian Basque, who specializes in sports medicine at SMHC Orthopedics and Sports Medicine. Dr. Basque, thanks for being on the show.
Thank you, Robert, for having me.
So we'd like to start out the show by finding out a little bit about our guest. How did you come to study sports medicine, and how did you end up at SMHC?
Sports medicine just seemed to be a good fit for me for practice. I always have been involved in sports and athletics, and then when it came into deciding a field of medicine, I just felt it was a natural fit.
And what kind of sports did you play, and were you involved in?
I played soccer and baseball, and then a lot of winter athletics, snowboarding, skiing growing up. So that's one of the draws to Maine. I've relocated here from Pennsylvania, where I did most of my training, and I grew up in Massachusetts, just about an hour down the road.
And how in particular did you choose Southern Maine Healthcare?
I was looking at, a combination of somewhere I would enjoy living and a good medical system. And when it looked at coming back into New England, I was kind of focusing on Boston, and then I found out about Maine Medical Center and Southern Maine Medical Center and piqued my interest, and there was an opening at Southern Maine. And once I came up here and met the group and met the practice, I knew right away it would be a good fit.
Now, I introduced you as working in orthopedics and sports medicine. How is sports medicine different than orthopedics?
Sports medicine, the way that I practice is non-operative. So orthopedics in general, it sees bones, musculoskeletal injuries, and progresses on to operative intervention, where I don't. I do a lot of diagnostics with ultrasound work, and even working with sports medicine center as far as prehab or strength and conditioning. But I also manage stuff with injections that for those individuals that either can't have surgery or don't want to have surgery.
Now, you referenced the Sports Performance Center, and SMHC has one in both Saco and Sanford. Do you actually go there to treat the athletes, or do they visit you in your office?
Usually I see them in the office and refer them over, but I also get referrals from them in the opposite direction, as there's a lot of people who go there just for strength and conditioning and might find that they have some kind of pathology that was undiagnosed, and then we can also take care of them that way.
And do you treat people who are also not athletes?
Yeah, I treat all injuries, really. It doesn't have to be athletic population. It just has to be pain, knee pain, hip pain, elbow pain.
So what would be a typical injury that you would see frequently and treat?
On the non-sport side, see a lot of arthritis, a lot of tendinitis, whether it's the knee or the shoulder or with the rotator cuff. And that also diagnose a lot of, either trauma, ER follow-ups, they had a fall, concern about a rotator cuff. And then in your athletic population, you see a lot of strains, especially with the knee. A lot of ankle sprains are big, and sometimes something that primary care aren't comfortable treating because they're concerned, especially in pediatric populations, whether there's an injury to the growth plate or if it's just the tendon. So I see a lot of young individuals.
You mentioned pediatrics. How young are your patients?
Yeah, I don't really have a cutoff age range on either end. I see 2-year-old last week up to 95-year-old last week. It really depends on what's going on with the injury.
Now, are there things that the athlete and also the non-athlete can do to protect their joints and muscles and not end up in the doctor's office?
Staying active is really key, whether it's doing what you can do, too, whether it's out going for a walk every day of the week, a couple miles, or getting into the pool for a swim aerobics class in the elderly population. Anything that can keep the joints moving, keep your flexibility and muscle strength.
Now, why should someone choose a sports medicine specialist?
Well, I think my goal is to be available. I don't have the constraints on my schedule that's a lot of the surgeons do, being in the operating room. So I'm available for those injuries that are, happen quickly, and either parents or somebody wants to get their child in seen quickly, and then kind of direct care. If it is something that does end up needing surgery, that's fine. I can easily transfer care over to one of my partners, and then they're also more informed, and they probably have more information now that they've come to see me. So that's a great reason.
How quickly can someone get in to see you? Do you have same-day appointments available?
Usually we have a couple same-day appointments reserved, if not within 24 hours. A lot of times I'm available even to look at the x-ray too. So if someone calls and they say, hey, I need to be seen today, I'm able to either pull up the x-ray and say, well, I'd like to get you in tomorrow or maybe even a few days, because not everything that I see in the office the same day, I can treat that same day. That goes along the lines with fractures. And it happens a lot with young kids, and parents are concerned, and my child has a fracture or a broken bone, and they want to be treated right away. Well, sometimes depending on the degree of swelling, we can't cast them right away. So sometimes I'll look at an x-ray and say, yes, I'll get them in right away. And sometimes I'd say I'd prefer to wait a few days because I've seen the ER, the urgent care, has put them in the proper splint. I know that the fracture is taken care of, but we'd like to see them back in a few days so we can treat them properly then, instead of having to have 2 appointments in the same week.
So what's the typical course of treatment and length of time that someone would come and see you to get treated?
Depends what it is. I mean, it ranges from 1 appointment maybe. So somebody comes in with some rotator cuff tendinitis, depending on what they've done before, whether it's medications or not. There might be an availability to inject that joint and provide them pain relief and get them working with a good physical therapist, and I may not need to see them back again. I tell most people that when we work on muscle strengthening, that takes 6 to 8 weeks. So that's the time frame we look through for when they're in physical therapy. And sometimes that 6-week mark or that 8-week mark comes and they're feeling much better, or the pain is resolved, and I don't need to see them back. Then on the opposite end of the spectrum is we have your broken bones, your wrist fractures, stuff like that, where I'm going to cast you. I'm going to see you back in 1 week's time because we want to make sure the cast fits well. And if the swelling's gone down, sometimes we might need to change a cast. And then we're also going to take in a repeat x-ray to make sure the alignment's good and nothing's changed. And then we're going to follow that patient serially over the next 6 to 8 weeks with x-rays and cast change.
And are your services covered by insurance?
Yes. I work just like you would a primary care doctor or any other specialty.
Now, how has the science of sports medicine and movement changed over the last 20 years?
I think there's been a lot more push for what we kind of call prehab instead of rehab. Rehab would be after an injury. We try to rehabilitate you back to what you were before. I think prehab, which the sports medicine centers I think do a good job with in this area, is try to get you strengthening and make sure you don't have weaknesses that can open you up for injury during sport or during life.
Now, one of the main topics of discussion in sports these days, obviously, is concussions. And I think in youth sports, there's a concern that should very young athletes be participating in contact sports. What do you recommend to parents? They want their children to play, but they're concerned about concussions. What do you recommend?
I think the awareness on concussions now is greater than it's ever been, and with that, a lot of good things have come. But as far as if you're deciding whether or not to put a child in sport, and that is your concern, I think finding a good coach, making sure that they have good technique, whether it's tackling, not using the head, not using the helmet, are all things that parents should be aware of. As far as, seeing concussions more in football than other sports, probably slightly, but surprisingly enough, there's a lot of non-contact sports I see concussions for. See a lot of cheerleaders for concussions. There's a lot of stunting and a lot of falls there, and sports that people just wouldn't probably associate with concussions. So the risk, I think, is there throughout most sports. I don't have a hard and fast recommendation on any sport of not participating. I think everything just needs to be with safety in mind and proper equipment and instruction.
Now, I've heard about something called impact testing that can be done on athletes or other folks who are at risk for concussion. Can you tell us a little bit about that, how that works, and why that's important? Impact
testing is a tool we use that needs to be done prior to concussion. So the impact is a test on the computer that tests reaction time and other modalities. And what it does is it gives us a baseline to say, after concussions happen, is this patient back to their baseline? That baseline is different for everybody. That's why it's important that impact is done prior to an injury. It's not as if we're just using this and they have to hit a certain mark. The certain mark is individualized.
Now, if a parent wants to know more about impact testing, or they want to make sure that their child has it, is that something they would go through their pediatrician or primary care physician or coach? How does that work?
Most of the schools are doing impact. So most schools, you come in and prior to sport, they have an impact test done in the fall. If for some reason they're not a fall athlete, I believe that they're working with the athletic trainers prior to their sport. So the athletic trainers are really the ones that are in charge of the impact testing, usually before and after concussion.
I realize every situation is probably different, but what's the average recovery time for concussion?
Every concussion is different. Every concussion in the same individual is different. The one thing that seems to be kind of consistent is the more concussions you have, the recovery sometimes gets a little longer. Not for everybody, but we always say no concussion is the same.
Now, Dr. Basque, are there findings that show that extreme exercise for youngsters, it maybe isn't a good idea? For instance, would it be good for a 10 or 12-year-old to run a marathon? How does that affect the young person and the development of their growing bones?
So extreme exercise, I don't think would be good for a growing pediatric population. Extreme anything, I don't believe is good. It doesn't have a negative impact that I know of. Weight training prior was to think that it would interrupt bone growth. We know that's not true. But I think that the trend of extreme or all-year athlete playing the same sport, we now are seeing a lot more consequences from. You have these kids who are playing either baseball year-round or field hockey year-round, for example, and the incidence of overuse injuries is much greater. It's much better for an athlete if they're going to play sports year-round to have variety. So whether that's 3 seasons, they want to play soccer year-round, but 3 of them we let them play soccer, and maybe 1 we switch up to track and field or baseball. Or people think that to make it professionally and they're a good athlete, they need to be concentrating on their sport year-round, and it turns into burnout in the athlete and the child. Sometimes the parents aren't even aware, and it also increases risk for injury. So early sports specialization, we're trying to get away from at this point.
Now, sports is such a big part of our culture. What advice do you give to young people and to older athletes?
I think that goes along the lines of kind of what we were just talking about is variety. Sports are great, athletics are great, but you don't want to be doing the same thing all the time. So getting into multiple sports, different type of activities, whether mixing up with running and swimming, avoiding a lot of impact, high impact activities, even marathon runners. I see more runners with knee pain than anything, and it's just years of high impact, whether it's running on pavement or outdoors. So varying exercise, I think, is most important.
Now, along that same line, a lot of the older athletes, the weekend warriors, they've already put a lot of wear and tear and miles on their joints. Do you give any guidance on how to modify exercise so that they can keep active but not risk injury?
I think there's always a way to either modify or give recommendations of change. If someone had those questions, we really sit down and I like to see what they're doing as far as exercise and see where we can make recommendations. I think that's another area too that the Sports Performance Center handles well. I tend to send more of my athletic population there, whether it is for physical therapy or just training in those situations. Just more information, giving them guidance of how they could change their program to either stay at the same activity level that they enjoy, but with less risk of injury.
You're tuned in to Medically Speaking, and we're talking about sports medicine and orthopedics with Dr. Christian Basque from SMHC, and we'll be right back with more of our discussion coming up right after this.
Not every boo-boo is an emergency, but it still feels like one. That's why Southern Maine Healthcare offers walk-in care. You'll find compassionate care at wonderfully convenient locations. Open 7 days a week, no appointment necessary. For those times when the unexpected happens, or you're just not feeling great, look for the orange ball as your sign of the best walk-in care. In Kennebunk, Saco, Waterboro, and Sanford, Southern Maine Healthcare, a member of Maine Health.
And we're back with our guest, Dr. Christian Basque from SMHC Orthopedics. Now, do patients need a reference for your services?
They need a referral over to sports medicine. Their primary care can put that in. Sports medicine or orthopedics is enough to get you over to see me.
Now, Dr. Basque, let's talk about the treatment of fractures for a minute. In the old days, you'd get a plaster cast, and that would be on for several months. I'm assuming things are a little different now.
Yeah, so we don't use plaster anymore. The casting material we do use comes on a roll, goes on very quickly. When we get it wet, it hardens into a cast, and the big advantage of the stuff that we have now is, you can x-ray through it. So you can take your x-rays in a cast. Sometimes we want to position a fracture back to how the bone naturally sits, and we'll do that, and we'll cast them, and then we can take an x-ray immediately after, make sure that that fracture hasn't moved at all. Changing casts are very easy. We use a cast saw, and kids are always scared that it's going to cut them. It doesn't cut skin. It just vibrates at a high rate and cuts the cast off. Now,
with these new materials and the fact that you can x-ray through the material, are people in casts for a shorter period of time now?
I think, bones heal in about 6 to 8 weeks on average. Pediatric population much quicker than that. So we cast, and then what I try to do is depend on function, lifestyle, your occupation, and how interrupting a cast can be in life. We try to get you out and maybe brace and use a splint afterwards, something removable where you can shower with, where your cast is on and you have to keep that covered and dry when you bathe, where the casting material itself is fine to get wet, but it's always the padding inside that gets wet and can be unpleasant.
Is physical therapy required after a fracture, or does it depend on the type of injury?
Depends on the type of injury, the age of the patient, the function that the patient had prior. Most kids say very, very rarely would I ever send somebody to physical therapy after a fracture in a pediatric population. But an older individual, elderly patient with a wrist fracture, you're immobilizing a joint for 6 to 8 weeks, let's say, and sometimes, there's a lot of stiffness and lack of range of motion after fracture. So our physical therapists and occupational therapists are great, and they have a lot of availability and can really work with you to get that range of motion back.
Now, you have quite a few diagnostic tools at your disposal to figure out the best course of treatment. And with regards to the older patients, what are the options that you have in terms of these diagnostic tools?
Well, we always start out with x-ray. Usually by the time you make it to me, if you haven't had an x-ray, we're going to get one. It's quick, it's easy, it's non-invasive, and that can diagnose a lot of conditions. Next, moving up is ultrasound. I have an ultrasound machine with me. I'm in a couple different locations in Biddeford, Sanford, and that always travels with me. And that can look at your ligamentous, your injuries, your muscle belly injuries. It can look for effusions or fluid as far as bursitis or a knee effusion. And the limiting factor with the ultrasound is intra-articular, or in between a joint, because it can't see through bone. So then our other study would be our MRI, which gives us picture of bone and tissue, complete picture. One misnomer is everybody wants an MRI these days, and everybody comes in the office asking for an MRI most times. And MRI is expensive, and though it's a good tool, there's a lot of stuff that can be diagnosed, or most stuff can be diagnosed without one. And I usually like to encourage patients who ask for or request an MRI that, I don't order one unless it's going to change treatment. So if we have a condition that we're suspecting that, fits with the exam, it fits with your history, it fits with the injury type, and getting an MRI might confirm the diagnosis, but if it doesn't change the treatment, there's not a need to do it, because we're just ordering a big test and costing the individual money, where we could probably fix the problem without it. So if I can conservatively treat something, I will, and MRI has its place. It's great for diagnosing, interarticular stuff as far as meniscal injuries that we can't see on x-ray or ultrasound of the knee. But I think having our expertise in what we do, I think, trusting our opinion a lot of time is not just ordering the MRI because people want it done.
So do you feel that these diagnostic tools help patients avoid surgical procedures when they don't necessarily need them, both because of your specialization and because you can get more information from these diagnostic tools?
Ultrasound has really stepped up and is becoming a great tool in the field of sports medicine. I think in a few years, fortunately where I trained, it was part of my training and my fellowship. It's not yet required, but soon I believe it will be. It will be required training in the field of sports medicine because it's that useful. That being said, I do a lot of work with rotator cuffs as far as diagnostic. We can look at the rotator cuff and observe any tears. That way we do not need MRI. Or if a patient is older and they have a pacemaker and they can't get an MRI, it's a good tool to have ultrasound to look at a rotator cuff injury. It also is great for needle placement. There's a couple different shots we could do, whether it's in the shoulder or the hip or structures that are deep, and the ultrasound is useful to see the joint and actually see the needle and guide it directly where we need it to go. That has changed, I think, the practice around here with a lot of hip pain. I see a lot of people with hip pain, and I have my partners refer a lot of people to me with hip pain. People who might not want surgery yet. The question might be, is this truly hip pain? So what we can do is we see in the office, and we do an injection in the hip under ultrasound. So the hip is a deep structure, but we're able to look at that joint with the ultrasound and direct the needle right where we need to go. In the past, all of the hip injections were done in the hospital under fluoroscopy, which is live x-ray. So you'd have to go to the hospital and be in radiology, and a physician would make sure the needle placement is over the hip using x-ray and inject the hip that way. And now I think we've removed that step. It's more convenient for patients. It's easier. And it gives good results.
Now, is this procedure available in both the Biddeford and Sanford office?
Yes, I can do that in Biddeford or Sanford, as long as it's scheduled with me. I bring the ultrasound with me to either office. We've had a couple good success stories I know one gentleman who has severe arthritis in the hip, but he continues to work construction. He is not ready for a replacement. It doesn't fit in his life, and I think having a replacement might limit his job afterwards. So his goal is to get through a few more years until he retires, and he sees me a few times a year, and we inject his hip, and he says he feels great, and it allows him to do what he needs to do.
So that was going to be my next question. It sounds like these injections can last for months and give you a lot of relief.
Typical with most of these injections, the earliest I would ever want to repeat an injection is about 4 months. That limits to about 3 a year. It's something that, we inject a lot of people, and they can have 8, 12 months relief, even more. Things vary depending on degree of arthritis, degree of activity. Everybody always asks me, it's the first thing is, how long is this going to last? And I can't give them a finite answer because it varies. But we had a lot of relief with people getting them once or twice a year and really changing, their livelihood and their pain level.
So in general, at what point in someone's treatment would you recommend that they move on to a surgical option? It sounds obviously like you've got a lot of tools to help avoid a surgical option, but at some point, at what point do you recommend that surgery is the way to go?
So there's no black and white answer to surgery or not surgery, in my opinion. Everything that we do is kind of tailored to an individual. But that being said, rotator cuff is a common injury we see. Older population, you don't have rotator cuff tears in a younger population. But after falls or other type of injuries, what our concerns are is there a tear? Is the tear a full thickness tear, or is the tear a partial tear? So we know now that a full thickness tear does not heal. So a muscle and tendon are under tension, especially in the shoulder, and when that full thickness tear occurs, which means it's completely torn through, that muscle is going to retract. And because that muscle retracts slightly, the ends do not heal back together. So that is a reason for surgery. That being said, if you're the elderly population, you have a tear because of a fall, you might not want surgery. Our goal in that patient is probably just pain control. If we can get you pain-free, you can touch the top of your head, and you can get your hand back into your wallet. You have the range of motion you need to go on with life, that's fine. And some people choose that option. Now, your middle-aged population, or sometimes even depending on occupation, you might need full range of motion. You might need full strength in that shoulder, and that's when we talk. If there's a full thickness tear, then surgery is a great option. And at that point, if that's something diagnosed and is needed, I can transfer care over to one of my partners for surgery. As far as partial tears, are partially torn. It causes some pain, but it doesn't mean that we're going to have a lack of range of motion or even lack of strength. So that's another thing, again, pain control and getting you working with a great physical therapist to make sure you continue to have range of motion and the strength you need, and that most likely doesn't need to be treated operatively.
So a partial tear, is that something that can be repaired on its own, or is that only something that can be repaired surgically?
So as far as healing and coming back together as it was prior, unlikely, but healing to where you don't have pain and you have strength, yes. Surgery is, for certain things, tears is the only way to fix.
Now, for folks who are listening to this and they want to be active and remain active, are there things that they can do proactively to stay healthy and avoid injury?
Exercise, and that's different for everybody. If you coming from a background where maybe you need to lose some weight, or you've never exercised, never been to the gym, I think your goal is to start with walking. Get out a few times a week, maybe 3 times a week, and start walking for 10 minutes, and hopefully build that up to 30 minutes per day, and then every day of the week, and making little changes as far as not parking close to the building. I see a lot of people with knee pain, and I want them to be mobile, and they say they don't know how to implement stuff. Well, start small. Park at the end of the parking lot when you go grocery shopping. Use a cart and walk around. Go to the mall. Do a few laps in the winter. And then for those people who kind of want to make the next step and are unsure of what to do, find a good strength and conditioning coach. Find a good trainer. Explain to them either an injury you're trying to rehab or something you're trying to prevent or your goals, and have them really tailor a program for you. Doesn't mean that you need to work with them every time and a few times a week, but I think it's a great starting point to getting you familiarized with exercise and activity and getting you to a comfort level of stuff that you can do on your own.
Now, if someone wants to schedule an appointment with you, Dr. Basque, what's the best way for them to contact you?
The easiest is just call. We have designated schedulers just for our department in orthopedics. So if you can call 207-283-1126, that's the main line here in Biddeford. And then the Sanford line is 207-324-1488. Either of those numbers for either location is great. People can transfer you if you needed, but we have a good team of schedulers who are used to this and can really direct you to the right place by asking you a few questions, whether it's me or somebody else in the group, depending on your injury or your needs. Or if you need to look up online, www.smhc.org, or you can simply Google SMHC Sports Medicine or SMHC Orthopedics. I've done it myself a couple times. Our website comes right up.
Well, Dr. Christian Basque, thank you for coming down to the show. We really appreciate your time, and it was great talking with you.
Thanks for having me.
You've been listening to this week's episode of Medically Speaking. Join me next week at this time for a new guest and an enlightening discussion about healthcare in our communities. Brought to you exclusively by Southern Maine Healthcare, your trusted resource for healthcare in Southern Maine.